we're working to really build, build a social prescribing student movement across Canada based on our core values of collaboration, education, advocacy, and innovation. So our work really ranges from webinars like this aimed at increasing awareness and education to also working with school faculties to have social prescribing integrated into our curriculums. And so we think is really important to really bring this message to medical students and other health professionals alike. So inevitably, we're all working towards this goal of really improving the medical system and trying to get the system to recognize social factors as playing a real fundamental role in human health. And for coming out today, I think that's a really great start to see so many great names and faces who are all kind of joining in this initiative. Today we're kind of kicking things off with our webinar aimed at really providing an overview of what social prescribing is and why it should matter to us as future health professionals. So we're super lucky tonight to have a lot of great speakers and panelists with us who we're hoping can kind of give a variety of views ranging from different training levels and geographies to really show just how omnipresent social prescribing can and should be in the field of medicine. So to just kind of quickly go over the agenda for tonight, we're going to start with an introduction from one of our group members, Grace, who will provide a real student-led perspective on social prescribing. And then we'll also kind of continue on that theme with Hamaad Khan, who is a real champion of social prescribing and is a medical student over across seas in London, joining us in basically the middle of the night over there. And then we're going to conclude with a really great panel discussion with doctors Dominik Nowak and Grace Park, who will provide some really great insight into social prescribing as it applies to clinical practice. And then at the end, of course, depending on how much time we have left, we're hoping to have a bit of Q&A. And that's also when we'll be announcing our gift card draws. So lots of excitement to come. Yes, and also just some housekeeping. Anyone, if you have questions at any point, you can put them in the chat. We have a few group members who will be monitoring that. And also at the end, you're welcome to put them in the chat or speak out once we get to the Q&A period. So with that, I'd like to introduce our first speaker and teammate, Grace Moffat, who will be giving a brief introduction on social prescribing as a medical student in Canada. So just a quick background, Grace is an MD 2025 student at Memorial University in Newfoundland and Labrador, with thoughts of potentially pursuing family medicine or a related specialty in the future. And alongside medicine, she's an active researcher on barriers to opioid agonist therapy completion, and she loves to ski and do yoga in her free time. She's recently kind of discovered her passion for social prescribing through her work with our student collective and is trailblazing the social prescribing climate in Newfoundland and Labrador by starting a new chapter at Memorial. So with that, I'll pass it over to Grace.
Hi, everybody. So that's a little bit about me. So I've been asked to kind of talk about what it means, social prescribing from a student perspective. And kind of on reflecting about this, I thought about something in that I feel like at some point in all of our medical curriculums, we've been told that health is not the absence of the disease, but merely the presence of spiritual, mental, physical well-being. And so I guess this broader perspective has kind of been what has given rise to the concept of social prescribing, which I understand is a very powerful tool that can help us provide better patient-centered care and address the complexity of human health. So social prescribing has a lot of different definitions, and I'm sure we'll hear a couple different ones throughout the talk tonight, but kind of my understanding of this is it involves recommending non-medical interventions to patients. So beyond the traditional medications and procedures that we often see. So they include things like exercise programs, volunteering support groups, art programs, or gardening, whatever it might look like to you. So the goal is not just to address symptoms of a condition, but also to understand the root causes such as social isolation or loneliness or unhealthy lifestyles. So I recently met a patient who was diagnosed with late stages of diabetes. he noticed that his vision was declining over a course of several months. And so that's actually what prompted him to go seek medical attention for the first time in several years. And the doctor diagnosed him with late stage diabetes. He told him that he would probably lose his sight within a year and that his driver's license would be taken from him. So and he'd be on insulin and metformin for the rest of his life. So as a 45-year-old man with many kids, this seemed like pretty unfortunate news to receive. And it was when a doctor posed to him, "What if I told you this was a reversible disease?" that kind of puzzled him, because he felt like that was pretty far-fetched. He understood diabetes as a chronic condition, and how could a chronic condition be reversed? But with nothing to lose, he decided to tap into whatever this doctor was suggesting. And the patient was introduced to a group cooking class where he learned how to make plant-based meals, learned about different spices and different cultural cuisines. And within 3 weeks, he said that he felt that his vision was getting better. And within 3 months, his diabetes was actually completely, I guess, in remission. This is the proper word to use. And that was entirely due to lifestyle choices and in the absence of traditional medication. So to me, this is a story that's played in the back of my head a lot as I've recently started clerkship, and remembering the value of social prescribing as a very valuable tool in our medical toolbox as I think about the disease management with various patients. So in conclusion, social prescribing is a very transformative tool that aligns very closely with the values that we are learning as medical students. And I'm really, really excited for what the panelists will share with us today. And I think my only advice is that as medical students, it's really important that we remember that we can be teachers too. And so what we learn here today, remember that when appropriate to share it with your preceptors, because as we've all learned, there's lots of lifelong learning in medicine. And so it's never too late to learn. And oftentimes I'm sure your preceptors would be very receptive to learning about something that they might not have ever heard about. And that's it for me.
And thanks so much, Grace. I think that's some really great perspective and insight to get us started. So thank you again for all of that. Next, moving right along, we're going to be having a quick presentation from Hamaad Khan, who again is joining us all the way from England. So thanks so much for making time to attend today. To just give a quick bio and introduction of Hamaad. He's a graduate medical student currently working as a development officer for the Global Social Prescribing Alliance. He studied neuroscience at King's College in London for his undergrad, and then went on to complete his master's in global health and development at the University College London just before starting medical school. Hamaad is keenly interested in developing global health systems with a vision of health promotion and disease prevention. His research looks at international models of social prescribing implementation, and he's authored the first global report on social prescribing in collaboration with the World Health Organization and NASP, detailing advancements in social prescribing across 24 different countries. He's passionate about championing this learning in his clinical capacity to affect a wider systemic change in the future health workforce, and he co-leads the Global Social Prescribing Student Council, collaborating with student leaders around the world to advance social prescribing teaching across health curricula. And in 2022, Hamaad was the youngest awardee for the Hillary International Award for Health and Care Leadership in recognition of his advocacy in tackling overprescribing with medical education. So that's just a modest introduction of Hamaad, and I'll pass the floor over to you.
Thanks, Jess, and apologies for the long introduction. That's the caveats with putting everything on LinkedIn. But thank you, Jess, and it's an absolute pleasure to be here presenting to you all today and hearing much about the brilliant work that the Canadian Social Prescribing Student Collective is doing and galvanizing a student movement, and especially to talk to you as my Canadian fellow medical colleagues on the importance, purpose, place and value of social prescribing, not just in modern healthcare systems, but also its importance in modern medical education, and why your involvement is actually critical and crucial. But first, before I start, I want to provide some cultural context. There is, there is a huge, gaping and glaring paradox of modern medicine. And that paradox of modern medicine is that we live in the age with more medicines, more therapies, and yet also more illness. And so at a time when we have a huge concentration of drugs, and drugs are designed to revive, restore, and renew good health, why is it that we're not seeing unprecedented levels of good health and well-being? In fact, we're actually seeing quite the opposite. Because at the time of the greatest scientific and medical understanding, it seems ever harder to attain good health, good well-being, and good nutrition. That is the cultural context that we're surviving in, the paradox of modern medicine. But it just doesn't stop there. We're also in this age of aging, as Andrew Steele likes to call it. The WHO reported that in 2018, for the first time in human history, there were more people over the age of 64 than there were children under 5, and that by 2030, 1 in 6 people will be aged 60 years or over. So there's this crossing thread of larger populations with longer life expectancies and an increase in age-related diseases. And it's forming a, frankly, worrying pattern. More people are suffering more diseases in their old age for a longer period of time. So here in front of you, this is a graph from the Health Foundation released just a few months ago, and it shows a projection of population ill health here in the UK, showing that as our lifespans are increasing, our health spans, the time spent in good health and well-being, is decreasing. And with that, there is this implicit expectation of an increase in the burdens of multiple comorbidities, demand in health service and care provision. Older people are more frail, more susceptible to cardiovascular events, to dementia, to cancers, and all sorts. So is there anything that we can do? Well, we've medicated, and we've medicated, and we have medicated. We've enjoyed this incredible biomedical research, and now we have access to over 18,000 drugs at our disposal. So in the age of modern medicine, we can trust drugs. Give statins to reduce blood cholesterol, give metformin for diabetes, as we just heard, give Ozempic or semaglutide to reverse obesity, almost ad infinitum. You can see from this graph, and this was quite a damning report that was published in 2021 in the UK by the Department of Health and Social Care. This was a national overprescribing review. And it shows that in a 10-year period, so if you look from to 1996 to 2016, there's a complete doubling of the average number of prescription items per head in the population in the UK. What does that mean? Well, that means in 1996, if you were to go and grab 10 people at random, well, just a random group of people and ask them, how many drugs do you take? How many medications are you on? The common answer would be 10. If you did that same experiment just 10 years later, the answer would be 20. So in just a decade, ignoring epidemiological transitions of disease, we had a doubling of the prescriptions that are in that we're prescribing to our patients. And this is harming not just our patients, but also our health service and the patient health. The same report found that we're now spending £2 billion a year in the UK on unnecessary medicine. 10% of all medicines are considered unnecessary. The patient didn't need it, the doctor didn't need to prescribe it, and the pharmaceuticals didn't need to make it. And what's the consequences of that? 1 in 5 patients are in hospitals because of adverse drug reactions. Drugs that were unnecessary, drugs that weren't needed, drugs that are just causing them ill health. In the context of the time that we don't have enough funding, we don't have enough resources, there's retention and recruitment staff, and so we're creating this incredible surge and demand in health services that we don't have. The UK, like in Canada, has a system of sick care, not healthcare. We admit the sick, we tend to the sick, we care for and heal the sick. And when we're done, horribly, ironically, laughably, we put them back out into the conditions that made them sick in the first place, as Michael Marmot puts it. It's cyclical, it's fragmented, and it's acute care. Our health systems are beautifully and brilliantly designed to respond to crises, but they're not yet developed with a vision of health creation and disease prevention. And all the while, amongst all of this, the patient becomes a passive entity with little agency in their own care. This is where social prescribing comes in. Social prescribing asks to produce a model for healthcare, not sick care, creating health creation capacities in individuals and not just using health services. Writing about her cancer diagnosis, Anne Boyer wrote an incredible book called The Undying, and she wrote about this passivity in becoming a passive object in her journey to healthcare. And she says, we fall ill and our illness falls under the hard hand of science, falls onto slides under confident microscopes. And then there's this body, my body, that has no feel for uncertainty, a life that breaks under the alien terminology of medicine. She writes so beautifully about how empirical science does little to invite, respect, and care for the patient voice in her journey to a long-term sense of well-being and resilience. So in this context, the patient voice is hushed under the hubris of modern medicine. Osler very famously said, as you all will know, as in a medical audience, listen to your patient. He is telling you the diagnosis. It seems that we have decided to stop listening because 44.6% of our patients want more involvement in their care, and yet at a record high, 10% feel disregarded. Yet, social prescribing invites that patient voice. It asks them not just what is the matter with you, but what matters to you. It's about co-creation. Medicine can offer far more when we allow our patients the dignity and autonomy to direct their own care. Now, as a neuroscience student, I was incredibly fortunate enough to volunteer with early stage dementia patients in a social prescribing workshop. And this was for the first time it was my first time seeing how patients who were diagnosed with dementia were encouraged to not just submit to their symptoms, but to recognize and reconcile their identities in a sense of well-being. Every week, they would do drama workshops, they would set up plays, they would reinforce their memories with evidence-based medicine, cognitive memory exercises. And across this 2-month period, I saw dementia beyond the clinical gaze that was afforded to me in my medical studies, beyond the neurofibrillary tangles and amyloid plaques that we all quite know about. And I saw a disease that was otherwise too easily marked by loss and deficit. And the other thing that I want to talk about that social prescribing touches on is the power of diagnosis, the importance of diagnosis. There's this brilliant book by Anne-Marie Goldstein-Jutel called Diagnosis, Truth and Tales. And she writes it so perfectly. She says, the naming of a serious diagnosis is a powerful thing. It changes how we think about our bodies, our disorders, our futures, and even our identities. The naming of a disease can sometimes be more powerful than the disease itself. It influences our experience of life. It brings our awareness of our bodies forward in our consciousness. And ultimately, the sick body, the body that we're told to inhabit, the body that we are told we have, is the body that complains and creaks and it disobeys our intentions. What's the purpose of this? Why am I talking about this? Well, in the context of over-medicalization, unnecessary medicalization, limitless medicine, we burden patients with unnecessary diagnosis and disease. Yet social prescribing recognizes how we can encourage a system of care that prevents disease coming in the first place. And if you have that disease, it enables a sense of resilience. How can you combat that disease? How can you reconcile an idea of well-being? Because disease is not a fate or a burden for you to bear. Yet medicine has the complete opposite of that. There's this other beautiful book by Jan Grew, rather, he's from the Netherlands, and he wrote a memoir, I Live a Life Like Yours, talking about his disability. And he talked about the clinical gaze, and this is another thing that social prescribing really removes. It's this unnecessary clinical gaze. He writes, what is this gaze, which is so sharp and penetrating, but simultaneously dull and disinterested, that separates things that should not be separated, and at the same time mistakes one thing for something very different? Jan here is talking about from his lived experience as a disabled patient, how doctors are unable to appreciate what matters to him, unable to appreciate a long-term sense of well-being, and unable to appreciate a holistic journey of care. We can diagnose, we can label, we can stigmatize, we can medicalize, but what does a good life and a good quality of life look to you? We never ask that in medicine. And so the ultimate question that we ask when we encourage social prescribing movements is we invite a space of criticality, right? It's about, asking the two fundamental questions. what is medicine for and what is a doctor? Because if medicine is for empowering and enabling our patients, and a doctor is a person encouraging that empowerment and that journey of our patients, then we don't always need unnecessary medicine. This isn't about destigmatizing or stigmatizing rather necessary medicines, but it's about not relying on medicines that aren't needed in the first place. So with this clinical gaze, it's important to see our patients as they are and not just medicalize unnecessarily. But I also want you to not just think about the patients that you see, but the patients that you will never see, because that's where social prescribing makes the most effort. The patients you'll never see are the patients who don't have the privilege to come to your clinic. These are the patients who don't have the privilege to navigate their health systems or communicate their stresses or concerns. These are patients, people, your patients, who are the most dispossessed, disenfranchised, and disregarded by society. By working at the community level, social prescribing makes sure that as communities thrive and people have the health creating capacities, our most vulnerable populations thrive with them too. And so that's what you're being a part of. Social prescribing is about creating a cultural change. How do we create that cultural change with medical education? It's about redefining perceptions of health. That's with medical education, the future generation of the health service, understanding that health isn't just an absence of disease, it's an injection of a sense of well-being. But it's also by redefining perceptions of health that you're able to step forward and reform systems of care. And finally, by reforming systems of care, you're able to revitalize health for all, health specifically for the most disenfranchised, dispossessed, the most vulnerable populations. I'm incredibly excited to learn about the developments of social prescribing around the world, and particularly in Canada. And I think there's much to learn from our own cultural contexts, and particularly from the UK, from Scotland, from Wales and Northern Ireland, from Singapore, and to see Canada join this global tribe of students who are taking the realms and becoming the future leaders of the change of tomorrow that's vitally needed is incredibly exciting. But I just want to say that your presence and enthusiasm today is incredibly important, because what it signifies is that you're ever ready to improve and better the health and well-being for all. And that is a social justice cause that you and we all should be deeply proud of. So thank you so much for the opportunity to talk today, and thank you.
Thank you so much, Hamaad. You never fail to inspire and motivate us all in the world of social prescribing. So thank you so much for coming. So moving on, we will next be transitioning into our panel discussion with Dr. Dominik Nowak and Dr. Grace Park, moderated by one of our colleagues from the Canadian Social Prescribing Student Collective, TAM. So just before I pass it over to TAM, I'm just going to give a brief introduction for Doctors Nowak and Park. So again, some pretty fancy bios, so bear with me. But Dr. Dominik Nowak is a family doctor and health leader. In addition to his clinical practice, Dr. Nowak's mission is to build teamwork across the health system. He's a trusted advisor to leading provincial, national, and international organizations toward a health system that is more kind, caring, and careful. Dr. Nowak currently serves as the president-elect at the Ontario Medical Association. He trained at McMaster University, where he specialized in family medicine and served as chief resident. He went on to finish a Master of Health Administration at the Institute of Health Policy, Management and Evaluation at the University of Toronto, and holds a Certified Health Executive designation by the Canadian College of Health Leaders. Dr. Nowak is currently a faculty member at the Dalai Lama School of Public Health in the Department of Family and Community Medicine at the University of Toronto. He is a recipient of the College of Family Physicians of Canada Award of Excellence for his leadership in Canadian healthcare. We're super fortunate to have Dr. Nowak with us today.
So good to be here.
Yes, thank you. And we're equally excited to have Dr. Grace Park with us as well. She's also a family physician and is the Regional Medical Director for Home Health and Specialized Community Services for Complex Medical Frail Seniors in Fraser Health Authority. She is a clinical assistant professor at the Department of Family Practice at the University of British Columbia. Dr. Park enjoys working with others to ensure smoother transitions for clients and seamless coordination of care within the healthcare system. She is actively involved with the divisions of family practice in the work in the Integrated Health Network and community actions and resources empowering seniors, and is also working in collaboration with the United Way British Columbia in the development and rollout of a regional social prescribing program. She's currently working with the Canadian Frailty Network in promoting the Avoid Frailty Management Program through the Pacific Regional Health Centre for Healthy Aging in BC. So again, super excited to have you both with us, and I'll pass it over to Tam to get the panel started.
Wonderful. Okay, we've had incredible content so far. We've gotten to learn a bit about what social prescribing looks like and the power of it and the impact it has. So I want us to start by talking about in a slightly more personal sense, like, what does social prescribing mean to you? Let's start with Dr. Park.
Social prescribing very succinctly means to me the integration of health and social care in our communities. As a family physician, longtime family physician in the community, too many times I saw social issues impact my patients' ability to remain well and to even comply with recommendations that I might be able to provide for them. So many times I heard, I cannot afford the diet that you're prescribing for me. I have to pay the rent, and that leaves me with this much money so that I have to buy higher fat content food or higher sugar content food, etc. So that sort of thing really impacts an individual when you're trying to do good service, to provide the best recommendation for your patients and for their long term. The social prescribing that I've been working to promote in Fraser Health is looking at how can other people in the community, non-clinical people, really extend our ability to reach our patients, to do the right thing, to live a better, healthy lifestyle. And so by making a referral to social prescribing, we're inviting a community connector, a link worker in the UK, community connector, they're called here in BC, to actually develop a relationship with my patient, usually an older adult, to figure out what their social context is, and what sorts of things impact their ability to live a healthier life, or what barriers there are in terms of living a healthier life. And so that person can talk about what are your strengths, what things are important to you, just as we've heard, and then develop a wellness plan that's co-designed, and then support them to overcome the barriers to some of the things that are healthy, like getting to exercise places or joining a club and working with others to increase socialization. And the CFN's Avoid strategy is something that I think your audience would be interested in learning about. If you just Google CFN and look up Avoid, it's an acronym to promote healthy aging and prevent frailty. So that's been my background, and social prescribing is really a wonderful strategy and a way of addressing social determinants of health, which we know make a huge impact on a person's wellness. And that is what social prescribing means to me.
That is incredible. And I love that that phrase that we talked about earlier, that what matters to you, really being the driving force of that connection. Dr. Nowak, go ahead.
Tim, thank you. I think of it as docs, we have a list of things or an idea of what we want to focus on during the visit. When someone visits you, you have a sense of, okay, I want to think about their diabetes. I want to think of their osteoporosis, maybe their heart attack from a few years ago, these sorts of things. Social prescribing says, no, that's not all there is to health. Actually, people come to you with different ideas around what health means to them. And social prescribing is really marrying those two thoughts of giving us something to do when someone's diabetes is actually impacted by them not being able to afford nutritious food, or their medical visits are impacted by them having to spend $1,000 a year on taxi services, which is a big deal. Actually, this is a very common thing that people experience, and on. And the social connection piece and all of these different things that play a role in health and how people navigate the health system, and how they experience well-being and what that means to them beyond just the biomedical model that we might initially learn in medical school. So that's what it is. It's mirroring those two philosophies for me, the medical model and then everything else, which is what people really experience.
And it really takes that medical model and makes it part of everything else, because those two things, coexist at the same time. I think for all of us, what sticks a lot is hearing more anecdotal experiences alongside all the great data that we saw from Hamaad. And I'd love to hear from each of you, what's one particular patient encounter, like a story or an experience that you had where you got to use social prescribing, and how did it impact the patient? Go ahead, Dr. Nowak.
Yeah, I think of an example early on in practice. So I was in an office building. I still remember the creaky staircase walking up, because it was just me walking up that creaky staircase, and maybe 2 rooms and just me and the receptionist in that office. And it's actually kind of lonely. And this ends up mattering when we talk about some of the solutions and social prescribing and how it could play out, because it was just me seeing people that day. And one of the people that I met when I was in that practice covering for another doc was someone I've seen a few times by then. And over those few times, their diabetes was just getting worse and worse and worse. And I couldn't really wrap my head around it. We were thinking of starting another medication. But I ended up asking that one more question. And it turned out that a few months before, this person's dad had been released from hospital. And they had a serious illness, had a hospitalization. Now this person was spending something like 20 hours a week caregiving for their dad. And obviously everything that played a role in their diabetes in their normal day-to-day just went out the window during this. And the answer to this wasn't necessarily adding another medication to their current diabetes routine, but connecting them with resources. And in this person's situation, caregiver supports. So there's actually an amazing resource called the Ontario Caregiver Organization in Ontario. They have a helpline for caregivers and families with these kind of situations who are in crisis, and they can offer some supports and connect them to resources. And then also a connection for the dad for an older adult access center with some programming that helped their day-to-day as well, and took some of that work off from the son. A few months later, their diabetes got much better without a medication, right? So I'm thinking of what Grace shared earlier and Hamaad shared earlier, of sometimes the answer isn't relying on the medicines and the overdiagnosis and overtreatment, but thinking about, what are we actually here for? What's our job as doctors? And what are some of the strengths of this person and the community that we can lean on to get them to a place of health, including both the biomedical stuff and then also what health means to them.
That is incredible. And you're totally right. We don't treat the numbers, we treat the patient, right? And when you understand the patient's context, it involves also treating their father or supporting them there as well. Makes a huge difference to connect to their social network.
And as an addendum, I'll say that's one of the big powers of family practice, right? It makes a difference to have a doc that can build a relationship with you, that understands you, that can see you month in and month out and year in and year out, because then that's when some of these conversations come out.
Yeah, you get to really know the social context of your patient. It makes a big difference. Going through this CARM cycle right now, I can tell you I've already been won over by the powers of family medicine. But I'll slide this over to Dr. Park as well. Could you share a patient example from your side?
Sure. I have the pleasure and honor of working with community connectors throughout our health authority. We've got 10 communities, and in each community we have a community connector that family physicians can refer to. So I have a couple of stories, but I'll relay one today. There was a fella, Jim's name. He suffered from depression and anxiety. He was 67 years old and widowed, and really not doing well. So he went to his primary care provider, who was a nurse practitioner in this clinic, and said, I'm not feeling well, and talked about the depression and anxiety, but he really wasn't wanting to take medication, wanted to explore other ways. So the NP made a referral to the social worker in her clinic, who talked to him for a bit and then made the referral for social prescribing. And with the social prescribing, it was at a local nonprofit organization servicing seniors, and it was called Brella. And in this organization, the community connector named Janice got to know James and spoke to him about what's important in his life. And it turned out that he really needed more affordable housing. So she was able to find a rental unit for him with lower rent, which was really helpful. And then in exploring further what might improve his mood, talked about his long-standing interest in music. He was a guitar player, but hadn't really had an opportunity to play for 20 years. So between the two of them, they talked about how he can take his music and help others. And so they co-developed a program called Happy Hearts, where they invited older adults from the community that had an interest in arts. So music, poetry, visual arts. And they had meetings once a week, and they would just come together and share what was important to them. And he would sing an opening song, and one was What a Wonderful World, and the theme was gratitude that evening. And he led this group, and together they even went to see a stand-up comedian downtown Vancouver. And they just did things to improve their lives, bringing in the arts and their interests. Well, soon his depression and anxiety went away. He was self-caring, self-managing, and has self-agency. And this is what social prescribing brought for him and in his life. So I find that a really heartwarming story, because it really was playing to his strength and that reason for living, his volunteerism, and the Japanese word ikigai, meaning in life, I think was really important for this man. And so I find that very rewarding, that story.
Yeah, as social creatures, we love to have a community around us to give us that sense of connection and that sense of meaning, right? And being able to use social prescribing to put that, further highlighting that in somebody's life is so powerful. I love the idea of that healthy hearts and happy hearts. That makes me happy hearing that. So looking at this then from the medical student perspective, we know our audience here today is already interested and they're intrigued in this concept. And I really want to try to put this into practice. So let's start by asking, how is this relevant to a medical student or a learner? I think we briefly mentioned this earlier, the idea of sharing this with your preceptors. But what are some other ways that medical students can start caring about and implementing this in their own perspectives of learning? What are your thoughts on that, Dr. Park?
I think if you have an interest in the social context in which your patient lives in, then you'll be looking around in your community to see what's available for your patients. And that's how I started in my practice. I just took an interest in the local paper that listed all the community events. And then I would point to them every once in a while with my patients, say, well, did you know that there is this walking club? Or did you know that there's a get up and go exercise program now at the rec center? And so by being a little bit open to acknowledging that there is this other way to help your patients besides the traditional medical model and medical prescriptions will keep you interested. And then you can start looking at, how can I help? Maybe there's a way of volunteering, or maybe just understanding how we can connect with them. And then if there's an opportunity for leadership, look into how you can actually be a champion for social prescribing for your group of colleagues, for your local regional health authority, wherever. And that's how I started. And it's really been a wonderful journey with so much potential down the road.
Fantastic. And Dr. Nowak?
Yeah, beautifully said by Dr. Park. I love the framing of start where you are, use what you have, and do what you can. And that's in each of those domains, right? The one-on-one encounters that you'll have as medical students, already so much opportunity there to think of, okay, what's something special that I can learn about this person, right? What's really going on with this person who I'm caring for, and what am I there for? What is medicine for? I'm thinking of Hamaad's questions, and what is a doctor there for? So how do I fill that role? And then two, the education piece, so sharing social prescribing in this approach with other students, with your supervisors, preceptors. A lot of folks are thinking about it. Social prescribing is naming it, putting a name to it, and then doing it more systematically, asking the questions, thinking about, can I be missing something here beyond just the medical model stuff that we think about really intuitively all the time. And then three would be the leadership piece as well. How can you contribute to a movement that recognizes that health is more than just, the purely biology of things, that there's so much more, that what happens in the clinic room in the hospital is only, maybe a quarter of health. And health is actually everything else that people experience in their day-to-day lives. And what's our role as physicians in contributing to health, or recognizing that, actually there's so much more to it than our offices and the hospitals.
Totally. It's understanding that the patient's context and their health goes outside of the room there as well. And like you mentioned, that first step is those individual interactions. The more you get to learn about your patient, the more you can understand the places where we can make changes and help with that growth, and then take leadership in a bigger community setting.
Yeah, practically, I'll say that a lot of the time you'll have a bit more time than your supervisors.
Yeah.
That's actually a great opportunity to think about, okay, could there be something else going on? And can I look into some of the resources as well, especially if you're in a place that doesn't necessarily have a link worker or a social worker or something like that. And you could check out Canada 211 or some of these resources that I'm sure we'll get to at some point today or in the future, to look at, okay, what are some of those ways that we can address social needs or connect people to social needs?
Absolutely. Yeah, it starts out with the small things. Like, I remember one patient interaction I had, like you said, having extra time as a medical student is a privilege, and getting to sit down and talk to this person who was, concerned about using their CPAP machine for their sleep apnea, and thinking, well, I just don't know if I can always keep using it. And usually we hear that and we think, oh, maybe there's something about the fit or something like that to discuss. But turns out this person was actually referring to having to go on a trip to see their parents who he hasn't seen in a while. And then from there saying, like, I don't know if I can afford an extra checked bag or an extra carry-on, and I don't know if I can take that with me. And that sparked my mind, and I was like, I wonder if there's something around this that that could be an accommodation made. And that's when I learned that actually every airline in Canada, at the very least, if not universally, has accommodations for medical devices, and that can come with you without cost. And being able to just make that connection and share that with him made that whole process a bit easier for him. And that wasn't even using the bigger system of social prescribing, which we're talking about today, but it's just using that skill we were discussing of understanding the patient's context and seeing what we can do. So definitely, as med students, we got to use our time that we get to hear them out on the small bits there. Our next question here is talking about the idea of fitment within the greater health system and the role of allied health workers in our team. So I know in the chat, as well as in the discussion so far, we've discussed the concept of link workers, of community connectors, and there are many places where these roles have not yet been embraced. But in spaces like the existing allied healthcare system, how does our role as doctors fit in with other professions like social work, which we've mentioned, or things that are more commonly seen in the Canadian healthcare system right now, where we can try to build social prescribing even when it hasn't been officially labeled quite yet? What are some of your thoughts on that, Dr. Park?
So our systems, allied health professionals, social workers, I work with them a lot. And in acute care, they have, a huge caseload to follow off, and they're responsible for several medical wards at a time. And so they'll deal with the social, ethical issues that arise in patient care on the floor. Very busy, but they'll do what they can to refer to community resources as they see fit, but they're not aware of everything that's out there. In the community, in home health, we have social workers, but they're often working with adult guardianship issues, really terribly horrible situations where only they are trained to be able to help them legally and going through all of the processes. And so they're not available. We just don't have the capacity in our allied health professionals in our health system. So with social prescribing, then we're bringing on a whole new crew of people that are there because they want to help that population. They're there because they know their community resources really well, and it's often changing all those resources in the community. And so those people in the community, if we can establish that, connector or the link worker, they become experts in what's available in the non-clinical sector. So that's why it's so important. And if you don't have that in place already and you're just thinking it, then just as Dominik said, if you start looking at what is available and making those referrals yourself, that is a beginning of social prescribing. If you can refer for meal delivery on a person who just recently had elective surgery and they can't cook for themselves, that is social prescribing. So you start doing what you can, and then you move toward the system level and make a difference.
Wonderful. And Dr. Nowak, what are your thoughts as well?
Yeah, I agreed with what Dr. Park is sharing. The reality is that teamwork makes the dream work, right? I would love for every practice in Canada to be connected to someone like a link worker or a community connector or someone like this, because at the end of the day, I know folks here have seen the paper from a few years ago that said family doctors, primary care physicians would need 26 hours in a day to complete guideline directed therapy for everyone. Family doctors are telling us in Ontario that they're spending 20 hours a week on paperwork with their EMRs, on administrative burden, all these different things. It's clear that one person can't be everything to everyone at all times. And I bet that a lot of that 26 hours, a lot of that 20 hours of admin burden is actually thinking about social needs, because we do take on that role in practices that aren't supported with link workers or community connectors. So I would love for that to be in more places as well. Until then, it's using what you have, doing what you can, and it could be relying on Canada 211. There's a fantastic website, a phone line with dozens of different languages, or places like the Ontario Caregiver Organization or local community centers, older adult access centers oftentimes have some kind of a link worker type role that can help people navigate some of the services nearby. So seeing what things like that exist in your community that you can connect to, even if nothing formal like a linked worker exists.
Good. I feel like that's a really important piece of homework for us to take home is just doing a little bit of digging, even if it's a few minutes, to find those local resources, because I think there's so much stuff in each community that exists, and like you've both said, once we find that and can share that small bit, it'll make a bigger difference than we might think it does.
Yeah, and social prescribing generally in this lens, social prescribing helps me be a better doctor. It'll help you be a better doctor, but it does sometimes come with, if I'm moving to a new community, I have to get to know, sure, the hospitals and everything like that, but also what are some of the social supports available, or what are some of those connector organizations or people available to the people that I'm caring for.
Mm-hmm. Absolutely. And I recognize our time. We're coming up towards the point where we want to open things up for questions and not keep our audience here for super, super long. But I also want to acknowledge the fact that often students who are joining in these calls have probably spent a full day of lectures either in pre-clerkship, or they've just got back from clinic or the hospital, and maybe their minds are not able to take in all the wonderful information we've put in 50 minutes. So I like to always ask the question, if there was one last thing that you wanted to stick in our brains and nothing else from today sticks, what's one message that you would want to be able to leave our students with, either talking about the impact of this that we can have in the future, or different ways to implement it, or just ways to change our thinking? Let's leave with one parting thought for our audience before we open up the question floor. Dr. Park, take it away.
So my mother is an elderly frail, and when you ask her what makes her happy and what makes her well, she's not going to say my appointment to the doctor or the last prescription he gave me. She's going to say it's my exercise classes at the community health center for seniors. It's the track that I walk around, even with my walker and cane sometimes. So all these things that I do with my friends and my community, that's what keeps me well. And that's what social prescribing does, is connecting people back to the community by association, rather than the institutions that healthcare often provides.
That's perfect. We always want to make our patients happy. That's the goal. And we don't do that with a prescription pad, that's for sure. Dr. Nowak.
I'll say, start where you are, use what you have, do what you can in each of those domains. And I'll put a plug into the Center for Effective Practice social prescribing resource. If you're thinking about social prescribing, you want to learn more, you want to share with other medical students or preceptors, the Center for Effective Practice just released and is updating a fantastic resource on social prescribing. Shows you how to talk about it. What are some example social prescriptions? What are some of those pathways to social prescribing, including the formal ones, the link worker, those types of pathways, but then also some of the informal ones that you can think about in your community across Ontario and across Canada. So check that out, cep.health/social-prescribing.
And conveniently enough, that link has appeared into the chat, which is
as if by magic.
Right? The beauty of our synchronized team here. So I would also want to welcome all students here to share a question either through the chat or through unmuting and joining us with your voices here. We leave the floor open. I see that we've got a little bit of that already. So students, please open the floodgates. Don't come all at once. Go for it.
All right, Tay, I'm just directing your attention to, I think Carrie had a question earlier. If you scroll back a little bit, that might be a good one to start with.
Yeah, that's true. I saw that we've had a quick here linked response, but I think we should also dig into it actually more verbally. Who are the community connectors here in Ontario? Dr. Nowak, do you happen to know more about a similar role or term there?
It really depends where you're practicing, right? So if you're in some of the team-based practices, like family health teams or community health centers, some of this is starting up, and there are some practices there that have folks like link workers or community connectors, or even the social workers are taking on some of this role in some, but not all. That's in those settings. In some of the non-team practices, it's a little bit more complicated. There are some groups that have access to someone that functions kind of like this. Those are usually pilots. But otherwise, it's a lot of informal, finding who are the organizations that you can lean on as a doctor and as a medical student. And those could be 211 is a big one for me, or the local older adult access centers, or the Ontario Caregiver Organization is another one for caregivers. There's some that have specific demographic type social prescriptions. So there might be a kids center or something like that with programming for kids and youth. So you really have to know your community in the absence of some of the more formalized programs.
I think just adding to that, if I can, just keeping your mind open and looking for those opportunities will make you become aware of what's available in your community. So just having that openness for the social context that your patients reside in is a really great place to start.
Of course, yeah, we definitely got to do some of that digging too, and find all these different tools and resources, not just the ones we're sharing here today. You brought up, Dr. Nowak, a point there about the youth as well, and I think actually this is a good bit of a teaser on one of the talks or events that our group here has been discussing, is trying to address social prescribing towards a younger audience or a younger patient population as well. So in the absence of a written question right now, I wanted to just hear both your thoughts on how social prescribing fits across the lifespan. The beauty of your roles as family doctors is you do get to see someone in all the age groups, and I want to hear some of the examples or ways that you think social prescribing could be used for the youngest of our patients, not just the oldest. Dr. Park, what are your thoughts?
Yes, we can go from cradle to grave for sure in family practice, as you know. And we just had an initiative start in my local community hospital where they looked at the maternity clinic to look for socially vulnerable pregnant ladies, and then intervened early, soon after the delivery, to ensure that the mom got proper nutrition and socialization, and that parenting skills were, available for them if they wanted. And then starting to sort of develop that healthy trajectory, regardless of what the background was for the mom and the dad. And so that's starting really early. And then in the adolescent years, we have a program in BC called The Foundry. And that's a collaboration between Ministry of Child and Family Health, as well as Ministry of Health, to try and develop a safety net for adolescents that are suffering a lot of times with substance use disorders and opioid crises that we have to live with these days. So a lot of that is social prescribing. And one initiative that I took notice of was peers supporting peers. And so people that are coming off the streets, they're starting to recover. They're actually being peer supports for those that are still out on the streets and using. So all through the spectrum, I think, of the human journey, we can introduce a social prescribing, and that will be a welcome partnership to the health system as we know it.
That's incredible. Building that sense of community, even for the youth that we have there, is quite important too. I see we have a question here in our chat as well. So I'll turn our attention towards that, recognizing that we can also talk more about our pediatric population in future sessions. What do you see as the biggest barrier to implementing social prescribing? Are patients generally receptive to it? Are there times where they might not be? What are your thoughts on that, Dr. Nowak? Go ahead.
Yeah, I would say most of the time, or almost all of the time, folks are receptive to it. Some of the barriers really the time piece. If you have a visit that maybe I'm only 10 minutes during that visit, it's actually sometimes hard to get in detail some of the the more comprehensive conversations you might want to have around social needs, where this person's at in terms of life, their strengths, all these sorts of things. And the easier pathway sometimes is to focus on the one medical issue if maybe fortunate just to have the one. What often ends up happening is they have several medical issues. Family practice medicine is getting much more complex. People are living longer, multimorbidity on many different medications. So sometimes it's actually hard to reach that conversation around social needs when you have to put out several different fires from a medical perspective. And that's where some of that follow-up comes into play as well. If you're lucky enough to have the opportunity for follow-up, where you could put out some of the on and then follow up and have some of those conversations in future visits.
Right. So time being a significant barrier, but then also taking advantage of the tool of follow-up that we have and extending your time, right? Our interactions don't have to just be the one time we see a patient. Dr. Park, what are your thoughts about barriers to implementing?
So we had a master's student look at what are the barriers for the seniors that are isolated. How do they become socially isolated that we know is so detrimental to their health? And it turned out to be financial, cultural, physical, and psychological. If you can think about those barriers, and so we need to make sure we've got culturally sensitive programs that they can attend. We've got to make sure they don't have financial issues, that they can't pay for a class at a rec center if that was going to be appropriate for them. And then mobility, including transportation to get to various different things. And then the psychological, the motivational interviewing that we do with them, how to set small goals that are achievable. So all of these are small barriers that, they're big barriers, but if you can break it down and over time, and we have the opportunity to do that in longitudinal care and primary care, so that's really great. But then again, with social prescribing, if you can get that community link worker, they can do all that, with your patient and their caregivers and their families and their social network as well.
Beautiful. And I love that this is evidence back too. It's great to see that we have a lot of the work in this going further. So being mindful of our time, I think we might have to tie in the end of our conversation here, and I'll hand things over to Jessica. We might be able to throw in some quick answers in the chat here as well for our participants, but I would like to thank both of you wonderfully for being here and sharing so much great wisdom, but also experience and showing us ways that we can get passionate about this and active about this. I think those are the best ways to look at this challenge that we have ahead of us. There's so much excitement we can build, and I want to thank you so much for your time.
Our pleasure. Thank you.
Yes, thank you so much. Just echoing what Tam said, that was some really great insight from you both. And we're super, super lucky to have had you both chat with us tonight. And also shout out to Tam for doing a great job of moderating. So thank you for that as well. Recognizing that we're a few minutes over 9, I'm just going to try and wrap things up quickly. So thanks again, everyone, for coming out. As a thank you, we're going to do our draw for the 2 Amazon gift cards. So lots of excitement there. So I'm just going to share my screen. I have all of the current attendees, minus our team members, in the wheel here. So we're giving away 2 gift cards. I'm going to do the first spin for our first gift card.
This is not sponsored by TD.
Okay, Megan W is our first winner. Is Megan still here? Yes, Megan Wiseman. Yeah, so Megan, if you're here, if you want to throw your email in the chat, one of our team members will grab that and we will send your gift card over. While you're working on that, I'll do our next spin for our second winner. Right, and then our second winner is Giorgio. Is Giorgio here? I'm sorry if I pronounced that wrong. Yes, it looks like he's still here. So if you want to also throw your email in the chat, that would be perfect. So big congrats to Megan and Giorgio. And yes, thank you again so much, all of you, for coming out and taking the time to chat with us today, and for all of the attendees for coming out to listen and learn. It's super inspiring to see so many aspiring professionals taking the initiative and dedication to really dive into this topic. If anyone's interested as well, as I mentioned before, the Canadian Social Prescribing Student Collective, we're always welcoming new members. So if you'd like more information or are interested in joining, you're more than welcome to reach out to any of us or send us a message on our website. And yes, if there are any follow-up questions as well, you're welcome to reach out to any of us. But yes, that is all for tonight. So thank you all so much again. I hope you have a great evening, and I hope to see you at our next event as well. Take care, everyone. Thanks.